Good morning, everybody. I think we can get started. Thank you so much for joining us. My name is Melissa Pennell, and I am the Director of Member Engagement at the AMA, and I will be your moderator this morning. Before I turn it over to Dr. Duggan and Dr. Sklar, I'll just take a minute to read the AMA's Land Acknowledgement Statement. The AMA respectfully acknowledges that we are privileged to live and work on the traditional lands of diverse, distinctions-based Indigenous peoples, including the Anishinaabe, Dene, Nehiyawak Cree, Niitsitape Blackfoot, Otipemisiwak Métis, Sioux Nakota, Stoney Nakota, Tsuut'ina, and more. This land has been gifted with many names, including Treaties 6, 7, and 8, the Métis Nation within Alberta, its Otipemisiwak Métis government, the 8 Métis settlements, and its Métis Settlements General Council, and the homeland of the Métis. The AMA honors the vibrant histories, languages, and cultures of the First Nations, Inuit, and Métis peoples of Turtle Island, now known as Settler Canada, who came before us and continue to thrive here today. So with that, I will turn it over to Dr. Shelley Duggan, President of the AMA, and Dr. Cameron Sklar, President of the AMA section of Obstetrics and Gynecology. Please go ahead, Dr. Duggan.
Good morning, and thank you for being here. As we were preparing for this news conference, I did notice some social media activity that made me pause. Melissa, will you put that slide up for just a moment?
Sure, just give me one moment. And there you are.
Okay, so this is a map that is maintained by a citizen advocate using data posted publicly by Alberta Health Services. You're looking at places where the obstetrical unit or OB operating spaces are or will be unavailable for varying periods of time across Alberta. This is an image that was generated on January 26. These are towns in Alberta where obstetrical care was or is unavailable at intervals. And that's an example of what we want to share with you today. There are gaps in OB-GYN care everywhere, and particularly in rural Alberta. Thanks, Melissa. Over a year ago, the AMA gave Alberta Health an acute care stabilization proposal. This is a comprehensive package to address the most common issues that are making it difficult for our members to practice in acute care, hurting our ability to keep the physicians we have or to attract new talent to come here. Like most acute care specialists, my obstetrics and gynecology colleagues are affected by a number of common issues addressed by the stabilization proposal. They also have challenges that are unique to their specialty. For example, since babies don't generally tell us in advance when they're going to arrive, obstetricians need to be on call 24/7 in our hospitals to bring these new people into the world. There have been persistent problems with stability of programs to pay obstetricians to be available when they are needed. For example, we know women's health, for another example, we know women's health in general is prioritized less in dollars and in research and in available access. This happens around the world, not only in Alberta, and we know that it's a problem, but it's particularly an issue for OB-GYNs for obvious reasons. They need access to OR time and to the support teams that work with them to care for patients. This event today is the fourth in the AMA's Acute Care Concerns series that we began last summer. Over the course of a year, we are shining the spotlight on various parts of our acute care system. These are specialty care spaces that some Albertans will never see in a lifetime, while other areas are more familiar. Obstetrics and gynecology is one that will be familiar to women and families, but these physicians are experiencing increasing pressure clinically, professionally, and financially. Our acute care system is under immense strain and is at risk. Physicians have solutions. AMA representatives have been working continuously with Alberta Health and Alberta Health Services to seek solutions. I am looking forward to my own discussions with the minister and her team. Our acute care information series has focused so far on cancer care, general surgery, and general internal medicine. I will now turn the microphone over so that we can move to the new focus of obstetrics and gynecology. Dr. Sklar, over to you.
Thank you, Dr. Duggan. There are a lot of issues facing obstetrics and gynecology practice. I think the media team will provide you with the full profile that describes things in detail after this briefing. First of all, I'm very confident that the care that obstetricians and gynecologists are providing is excellent, and we want Albertans to share that confidence. I truly believe that we're giving world-class care to the women in our hospitals in Alberta. As Dr. Duggan says, however, we are under increasing pressure from several directions. I'll focus on some of these most critical issues in my comments to come. So the first issue would be that obstetricians and gynecologists are being incredibly overextended and we're all burning out. We don't have the replacements that we need and things are becoming quite dire. Alberta does not have enough OBGYNs. I'm sure that all of us have seen this in the media coverage. There are the shortages that led to the closures of rural hospitals and OB wards, as Dr. Duggan's map has showed off the top. We've heard all the news reports about these shortages, particularly in places in southern Alberta like Lethbridge, but it's critical across the province. We have fewer OBGYNs per patient in our neighboring provinces. We know that our population is growing and is aging, and that means more patients and more complexity and more need. We are struggling to keep up with the demand, not only in obstetrics, but in gynecology and all the subspecialties that entails, such as urogynecology and gynecologic oncology. There are not enough resources and not enough of us to do our jobs as well as we would like. Excellent care is still being delivered, but is increasingly difficult to sustain. The situation in rural Alberta is particularly difficult. In any rebuild of rural healthcare, we truly need to prioritize OBGYN care. The second issue I'd like to highlight is the compensation and after-hours care piece. With fewer OBGYNs to provide care, we need to attract more to practice here, and this is becoming incredibly difficult. Alberta OBGYNs are among the lowest paid of the surgical specialties already, and this is no secret to our trainees and medical students and residents wishing to go into this specialty. We're also highly impacted, more than other specialties, by after-hours care, which includes nights and weekends. In major centers, there has to be an obstetrician on site 24/7. In my own hospital, the Royal Alexander Hospital, we have to have 2 obstetricians on call 24/7. In smaller centers, doing call from home can be allowed, but you're still on call and need to be available at any time during that night or weekend. After hours care usually prevents us from running our clinics during regular hours. But even when we aren't able to work in our clinics, we still have to cover business costs such as our staff, our space, and equipment. Some of our fees have been stagnant for 20 years. It is not competitive. The on-call requirements add to our complexity. Recently, Alberta Health Services has told physicians the number of acute care programs that there will be reductions or the removal of on-call payments as of April 1st. There are several OBGYN groups listed in this group of physicians that will have these stipends and on-call payments removed. There's intense work underway by the Alberta Medical Association and our physician leaders in discussions with Alberta Health. We need to be there 24/7, but we also need to be able to sustain that availability and to maintain our own financial health and pay for our clinic and our office costs. Availability and on-call must be addressed so that we can ensure we have a stable OBGYN physician workforce to be there when we are needed. I'm sure Dr. Duggan will keep everyone updated as things go forward. The third issue I'd like to highlight is the shortage of anesthesiologists. The shortage of this group of specialists is another huge issue for OBGYN. This is affecting all surgical specialties, but for those of us who work a lot after hours and work in women's health, it has a real impact. In our major centers in Edmonton, Calgary, and Red Deer, delivery rooms and anesthesia for emergency C-sections are generally available. For other gynecological work, however, we already have an insufficient level of OR time. Add to that the chronic lack of anesthesiologist services, and you're seeing fewer surgeries and longer wait times for women. Some of the conditions and things that our patients are experiencing are heavy bleeding due to menstrual issues, endometriosis, and chronic pelvic pain. These are debilitating conditions, but we can't get the OR capacity that we need to keep wait lists down. Many anesthesiologists left the province and the previous government terminated the agreement with the AMA, and those numbers have unfortunately not recovered. An additional complication is that chartered surgical facilities are up and running to try and reduce surgical wait times in some targeted areas. Gynecology surgeries have not really been given the access to chartered surgical facilities as of yet. And unfortunately, what we are seeing with anesthesiology is that those physicians are being drawn out of the regular hospital work into these facilities. So some wait lists may be reduced, but others will get worse. Let's get along here. So whatever we do, we have to address the supply of obstetrician gynecologists, and we have to decrease the burnout and ensure that women can access the care that they need throughout their lives. We need to increase the capacity for surgery by addressing the anesthesiologist shortage. I know that is being worked on. Perhaps team-based care with nurse anesthetists or other new models would be workable to make our supply of anesthesiologists go further. We could open procedural rooms in the hospitals for less complex procedures, and we can leave the big operating rooms for the cases where that is needed. This has been done at the Misericordia Hospital in Edmonton quite successfully. And that concludes my comments, and I will turn it back to Melissa for questions.
Pardon me, thank you. Okay, so as per usual, we'll use the hand raise tool in Zoom to conduct the Q&A. So if you've got a question, please just use the hand raise button and we'll just go in the order of hands raised. When I call your name, just come off mute to ask your question. And please do remember to introduce yourself and just let us know what media outlet you're with, if that's okay. I actually don't see any hands raised just yet. Oh, there we go. First one, Leo, please go ahead and ask your question.
Hi, Leo from Sitting Use Edmonton. So with the closure of the OBGYN, with a lot of those, how much Albertans will be affected by this closure? I know that major sites like in Edmonton, Red Deer, and Calgary is less to be impacted, but those small towns that has those, how much people or how much of an impact will this happen?
So I don't have the exact numbers from all of these small hospitals. Generally, the smaller rural communities do a smaller number of deliveries. So, a small hospital in, say, Whitecourt, Alberta, Northern Alberta, may deliver 300 babies a year. So if that hospital is closed, then you're going to see those patients that are going to be funneled into the major centers, typically, like the Royal Alex in Edmonton, or the Foothills in Calgary, or any other of the hospitals in Calgary or Red Deer. So generally what will happen is those services will close quite frequently, often due to either lack of an anesthetist in the town or due to the fact that there's the one family physician in town who does obstetrics is away on holidays or unable to work. And then those patients are forced to travel into the major centers, and it just increases pressure on the system substantially. So it's like a blockage in the system, and it's going to increase the pressure. But I would say at any one point in time, there could potentially be a few thousand patients who are pregnant in all of these small communities that could be affected by these closures.
And in terms of wait times with this closure, it's going to have longer wait times on even the major centers, correct?
Correct. So speaking from my personal experience at the hospital I work at the Royal Alexandra Hospital in Edmonton, we deliver approximately 7,000 babies a year. And so that you're looking at 24 or 25 deliveries a day. And if we're having 2 or 3 patients on some days come in from rural Northern Alberta because their local hospital is closed, yeah, they can come in and that can add significant wait time to receiving care. And quite an urgent situation. Some patients come in requiring a cesarean section, and it may be a 6 or 7 hour wait at times.
That's all my question for now. Thanks.
Thank you for that. Next, I see we've got Aaron. Please go ahead. I think you're off mute, Aaron. Are you?
I know. Sometimes I have tech issues. Yeah, Aaron Sousa with the Canadian Press. So I'm just wondering if you can touch a little bit more about, if you can offer some more insight into this problem specifically. And, because like you were mentioning, we hear about the shortages all the time, but can you touch a little more about what is causing this problem and what the risk is to Albertans?
I think a major cause is the fact that a lot of rural family physicians are getting away from doing obstetrics for a number of reasons. One of the reasons would be that just the lifestyle. It's quite terrible. As Dr. Duggan said, babies don't just come after lunch. They can come at 2 or 3 in the morning. If you're a very busy family physician in a rural practice and you have several thousand patients that you're already looking after, you can't really afford to miss you can't really be afford to be up all night and cancel your clinic the next day. Also, to add the litigious nature of obstetrics, it's a very high risk field, and our medical malpractice insurance is very significant. And that's also pushing several family rural physicians away from that specialty and leaving it to the specialists. So those are the two main reasons. And I think that a lot of the closures in these communities is due to the fact that rural healthcare is really in decline and in crisis, not decline, but crisis, I should say, that there's just a huge recruitment issue with rural family physicians who are providing obstetrics, and that's putting pressure on the system in the major centers. But I would say that those are probably the two main issues. It comes back to lack of recruitment of rural physicians providing obstetrical care. And I think that's mainly due to the lifestyle and the intense nature of the actual field of obstetrics, and the financial issues and the medical legal issues, I would say, that are not scaring, but deterring people from practicing that field.
Right. And so I guess my follow-up on that is, do you have any specifics or insight into, how this is affecting moms, for example? If they can't get in to see an OBGYN, these are expectant mothers, how is this affecting them?
I think it's adding significant stress, and we can see probably they're at an increased risk of poor perinatal outcomes. So if you can't get in to see an obstetrician or a doctor even until you're 30 weeks gestational age, you've missed significant milestones in your prenatal journey. So you've missed your chances for adequate prenatal genetic screening. You've missed the boat on timely screening for gestational diabetes. You can have significant more worsening outcomes. So myself, I've seen several patients over the past year who have presented to me with major medical comorbidities, some as bad as cystic fibrosis, type 1 diabetes, and they have not been able to get in front of a doctor until their 30 weeks gestational age, which is late in their third trimester. And what we can see, I think it's clear for anybody to see, and I don't think that I'd be overstepping by saying that the outcomes in these pregnancies can be substantially worsened. Anybody with medical comorbidities and these high risk conditions really need to be seen by an obstetrician or somebody very educated in antenatal prenatal care by before 12 weeks. And so we're going to be seeing worsening perinatal outcomes for the mom and the unborn fetus.
Thank you, Erin. Next up, she is not able to raise her hand, but Jasmine, please go ahead and come off mute to ask your question.
Thanks, Melissa. Yeah, I don't know what the button's missing on my screen, so thank you. Yeah, Jasmine with Global Edmonton. This is kind of following up to what Erin just kind of asked, but you mentioned that people are waiting longer before they even see a doctor. Is that the same for, I guess, what was the average wait for somebody who already has a doctor and one who doesn't, and they're just trying to find one before, as they're going along their pregnancy?
So I think that if you're one of the lucky Albertans that has a family physician, then yeah, most likely we are seeing those patients get referred into the specialty stream a lot sooner. But Dr. Duggan can talk more to that effect, that I think there's a million, if not more, Albertan patients without a family doctor. And there's just a lot of patients that they have no access. They can't even get into a family doctor for referral, and they're not aware that it's okay to show up to an obstetrical unit in the city to just receive care. And in my center, the Royal Alexander Hospital, we're seeing more and more of these patients showing up. Alberta residents with no family physician, and they're showing up 28 weeks not having seen a physician. They've had very limited, scant prenatal care, and we know that that's going to increase poor outcomes to the mother and the child.
And I guess my follow-up would be, we're speaking about just how difficult it is and the recruitment issues as well. I mean, what really more can be done to really bring more physicians and specialists to our province and to these rural centers?
It's a tricky question, but I mean, obviously, I think the government could potentially listen to our primary care proposals and our acute care proposals. I think that there needs to be just a huge investment in Alberta healthcare and retention of physicians overall. Um, I think it's a great specialty myself. I mean, I think it's wonderful, but it's very demanding. And unfortunately, the environment in Alberta over the past few years for physicians it's become difficult to recruit and retain people. I can say personally, I'm involved in the residency program for training obstetrics and gynecology residents in Edmonton. I think that we give world-class training. I think that we have two elite residency training programs in Calgary and Edmonton, and we are seeing a lot of those residents leave Alberta and go to other provinces. It's hard to retain. And I think that's the function of them. If you're a resident, you're here in this healthcare system for 5 years, and residents can see, and they know where they want to go. They know where it's going to be a nice healthcare system to work. So I think there needs to be some investment in our system to help hopefully recruit and retain those physicians in training.
I think too, it's important not to underestimate the burden of call because particularly in Edmonton and Calgary and Red Deer and perhaps even Lethbridge, they are generally doing in-house call, meaning they're there for 12 or 15 or 24 hours. And can't leave because so when things go poorly in the field, you've got to act quickly. So there's the issue of and then the challenge is quite a bit worse in rural in the sense that you may do the 300 deliveries a year, but you're in the middle of your clinic, and then you leave clinic. You leave those patients, and then you are also not getting remunerated for that clinic. And then if you're up all night, you face the question of, do I still do a clinic to see people and be able to make some money to cover my overhead, or do I sleep because I haven't had any sleep? These are challenges, and we really have to consider how we remunerate for call for physicians. So that they are able to practice safely and be paid. The concept of being paid to be available is one that is a challenge in Alberta.
Okay, thank you. Next up, we've got Jackie. Jackie, please go ahead.
Thank you. What do we have numbers, some statistics that reflect the challenges and the dangers, statistics of the increased risk to women and children because they're outside of those urban areas where care is more available?
I don't think there's Alberta specific data, but I think that that's a very wonderful future source of research. I think that would be something that should really start to be tracked. I think anecdotally, if you spoke to myself and a lot of colleagues, you would see that there is a big difference. There's a big difference in outcomes. It's unfortunate, but I think that a lot of patients who are living in rural Alberta, not they don't have access. They don't have the same access to care that you would have if you lived in Edmonton, Calgary, or Red Deer. So unfortunately, I can't give you any statistics off the top of my head, but anecdotally, I can say that I believe that there's a difference in outcomes. I think it should be looked at. I think it'd be great to capture that data.
Did you have a follow-up, Jackie? Are you good?
No, thank you.
Okay, thank you. I'm not seeing any other hands at the moment. Maybe just give it a second or two in case anybody wants to pop up. Oh, Leo, please go ahead.
Sorry, just thought of another question here. In terms of you mentioned about investment, what does AMA or as a OBGYN personally, what does the investment do you want that the Alberta government need to invest? Is it equipment? Is it even pay like the salary, the wage, since you mentioned earlier that it was one of the lowest paid as well? Is that what do you mean by investments?
To go back to Dr. Duggan's comment about call being available on call and in just after hours payments, there's an acute care proposal that the AMA has put forward to the Alberta government, and any physician in Alberta is free to bill certain fee codes to accommodate their after hours care. And I think those codes are the ones that have not changed in 20 years. Despite all of the inflation, we're getting paid like era 2000, year 2000 codes. So we need definitely those to be updated. So when we're talking about investment, I think it would be very beneficial to have more money put into those after hours codes. And the other huge issue in obstetrics and gynecology is that it's one of the most poorly remunerated specialties, surgical specialties, and it's an international issue. There's multiple complexities, but there's been multiple peer-reviewed literature papers published over the past few years showing that, gynecologic surgeries are paid at, much reduced rates than those of, urologists or general surgeons or ear, nose, and throat specialists. And that's for multiple reasons. But I think that there needs to be a huge investment in increasing the remuneration for gynecologic fees and obstetrical fees as well. Unfortunately, women's health has just it has not been invested in, and there needs to be significant investment in those fee codes from the Alberta government.
And Jackie, please go ahead.
Thank you. Do we have some idea about the number of like OBGYN per capita outside of the urban area? Like I'm trying to get some sort of a statistical base in my head of how thinly spread the population is compared to how thinly spread the OBGYN staffers are. Do we know those numbers?
I don't have those numbers off the top of my head. Anecdotally, I could say roughly, in Edmonton, there's about probably close to 60 OBGYNs for a population, the catchment area of all of northern Alberta. In a lot of rural small towns, you don't have a specialist obstetrician gynecologist. You have, that would fall to the family physicians who provide rural obstetrical care. And that number is, dwindled significantly over the past 25 years. We're just not seeing people come in and do that work anymore. I can think, north of Edmonton, just very anecdotally myself, the town of Whitecourt has one physician that can do a C-section, and there's a population of 8,000 there, maybe a catchment area, you're looking at 10, 11,000. Likewise, Barhead, there's one physician that can do C-sections. Edson, there's maybe a couple that are providing obstetrical care. Hinton, a couple, and these are all towns. When you start looking at the catchment area, there is, we're probably looking at tens of thousands of people that these physicians are caring for. And they obviously don't have the capacity or the time to look after those patients. And these patients are getting shunted into Edmonton.
Thank you.
Thank you. Erin, please go ahead.
Yeah, just had a quick follow-up. Forgive me if this is a bit of a stupid question, but I'm just wondering, because you were talking earlier about how you've seen patients show up, with major medical comorbidities or morbidities rather, late in their third trimester, and that you're seeing, these that you're going to see possibly perinatal outcomes for the mom and the unborn fetus. Just wondering if you could help me, sort of hammer that down more about, what kind of things encompass perinatal outcomes.
So if you have a patient presenting you, I've had recently with a severe autoimmune condition, and showing up at 30 weeks, what that typically means is the baby's will not have grown as well. So you can have a baby that's very small, for what we call small for gestational age or intrauterine growth restricted. That may mean that baby may be, once we finally see the patient and start monitoring the patient, treating the patient, we may have to deliver that baby prematurely to prevent a stillbirth. So you're going to be seeing increased risk of premature birth. A lot of women nowadays, we're seeing increased rates of what we call gestational hypertension and preeclampsia. And those are conditions that, there's a lot of good evidence that if we place women on treatment for it very early on in their pregnancy, preventative treatments, just by taking 2 baby aspirins a day, but starting by 12 weeks gestational age, that can greatly reduce their risk of developing gestational hypertension, preeclampsia. And if a woman develops these conditions, and again, that's another reason that we typically have to deliver infants very prematurely. So if you have a premature infant, you're seeing increased risks of respiratory distress in these infants. They're requiring multiple weeks, if not months, in the neonatal intensive care unit. And then these kids can be affected their entire life with learning delays, developmental delays. Not to mention that the mother who develops preeclampsia or gestational hypertension, that if they had seen an obstetrician and been put on preventative therapy, once they've developed preeclampsia, that substantially increases their risk for cardiovascular disease later in their life. And we're going to see downstream effects there. So those would be just a few examples.
Thank you. I'm not seeing any more hands at the moment. Maybe going once, going twice. All right. Well, thank you again for joining us today. We really appreciate your interest. If there's any follow-up, as always, please just reach out to media@albertadoctors.org. And yeah, thank you. Have a great day. Bye, everyone.